Great. So thanks everybody for inviting me. It's a pleasure to come and speak to you all about this. As was mentioned, my expertise is in ultrasound imaging of vascular conditions. Of course, DVT is one of the largest parts of our work. So I'm going to talk to you about primarily ultrasound diagnosis for DVT. So just quickly to run through what I'd like to talk to you about the different methods involved in diagnosing DVT, but primarily focusing on ultrasound. I want to show you some scan images and explain what it is that we see on an ultrasound scan. I want to touch on the NICE guidance for imaging DVT and just a few other little bits and pieces on the side. We come from an ultrasound background, so what we see is black and white speckly images, so it can seem a bit sort of obtuse and unrealistic to us. So I always like to remind myself about what it is that we're actually looking at, rather than thinking about black and white speckly things on a screen. So it's a mucky, horrible thing, as you all know, I'm sure. I'm convinced that you don't need me to talk to you about Virchow's triad, so I'm going to skip across this, but I'm sure you'll have all been very well aware of this. And why are we worried about DVT? Of course, the risk of leading to pulmonary embolism and all the complications that leads to, but also thinking more about the patient's longer term outcomes and looking at post-thrombotic syndrome, leg ulcers and that kind of thing, which is a huge burden on the NHS and does lead to significant budgetary implications. Of course, diagnosing DVT has lots of different aspects to it, and we can run through some of the parts of that: clinical examination and pre-test probability scores, Ddimer testing, various types of imaging. But as I've mentioned, I'm going to be focusing mostly on ultrasound because that's what I do and that's what I know about. So why do we need to look at patients with DVT? And on the left of the screen here, we've got the classic set of usual reasons why patients get referred to us for imaging for DVT. So classic redness, unilateral limb swelling, all of those real classic things. We also in the department here see a range of patients for lots of other reasons. So we have, patients who've got suspected pulmonary embolism when imaging of the chest is more difficult, but a range of other slightly strange and unusual indications. And we actually have found over the years that looking at some of these groups can be quite useful. And we do find sort of occult, proximal, sometimes DVTs in some of these groups of patients. Why do we need ultrasound at all? Can we not just examine the patients? And I'm sure, as you all know, the problem with DVT is it has lots of different conditions which mimic it symptomatically. So it's very difficult using only clinical examination and non-imaging methods to really be confident and have a diagnosis which is reliable. And that's why we need to move on to try and get a better understanding of the likelihood of a patient having DVT. The pretest probability scores, classically the Wells score, is used, and that helps to kind of triage patients a little bit, but in and of itself is not wholly reliable. So we do need to move on to testing. Ddimer testing, as I'm sure you all know, is kind of useful, and particularly if the Ddimer test comes back negative, is very useful for ruling out DVT. It's problematic, as I'm sure you know, that the specificity of Ddimer testing is very poor, and what that essentially means is because lots of different conditions will lead to an elevation of a Ddimer test, you can't say that someone who's got a positive Ddimer has a thrombus. You can only say that we can't rule it out, and therefore you need to then move on to imaging. And really what happens in reality is a combination of all of these things. And this is a pathway. I'm sure there are many others out there. I don't actually know if this is our most up-to-date version, to be honest, but it's an example of putting together all of these things that happen before the imaging just to try and get a flow and understand the likelihood of DVT being present. The NICE guidance is something I do want to discuss and to look at the sort of flow through this pathway. And if you look at the first thing that happens according to this pathway is to look at the pretest probabilities, and the patients are sort of stratified depending on whether they have a higher or a lower risk on the pretest probability. If we look at the patients in the high pretest probability group, the suggestion is that we should have a proximal leg vein scan within 4 hours, or if not, then treat them until the scan can be done within 24 hours. And then there's a need for repeat scanning. So these are all the areas where I get involved in this pathway, so where the ultrasounds may or may not take place. So let's just have a think about that for a minute. The NICE guidance, the first thing is we should scan within 4 hours if the Wells score is high. That's 4 hours. And if any of you are old enough to remember One Foot in the Grave, when I read this, this is how I felt about that. I'm not sure that many departments can manage to do ultrasound imaging reliably within 4 hours. So if we can't do it within 4 hours, we can then aim to do it by treating the patient in the meantime and trying to get the imaging done within 24 hours. Now, again, that's still quite challenging, actually. We can usually manage it during the working week. And even now we have some patients seen on a Saturday, but actually we're not running around the clock service. So 24 hours is still a challenging timescale to do it. And then for those who have a negative first scan but have a positive Ddimer, we need to repeat the scan after 6 to 8 days. And I'll explain a little bit more in a moment about why. It's worth noting that on the NICE guidance, the scan is for proximal veins only. And that's a very important point, which we'll discuss more. So what do we mean by proximal veins? This is a slide which shows the anatomy of the lower limb veins in terms of the veins that we can see on ultrasound. And you notice that proximal really includes everything down to and including the popliteal vein, and anything below that is classed as distal. So why do we need to repeat the scans for patients at 6 to 8 days? And this is because the scans are only for proximal veins. And the idea of the repeat scan is to catch any DVT that was in the calf that has propagated into the above knee veins. And we're going to come back and discuss that. But it's important to recognize that all the scans, according to NICE guidance, only need to be down to the popliteal vein level and not including the calf. So this is where my expertise really lies. And this is actually how do we rule out DVT on imaging. And we call it compression ultrasound. I'm sure you've probably heard it, compression ultrasound, because that's exactly what we do. We use the ultrasound probe itself to press on the veins and squash them down. And this is what it looks like on an ultrasound scan. So for any of you who are unfamiliar with ultrasound, what we're looking at here is the skin at the top of the image and looking down deep into the tissues. And you can see the common femoral vein being compressed by the ultrasound probe. And what that shows is that vein is completely free of any thrombus. Any thrombus within that vein stops the vein from being compressible. We can see adjacent to the vein, the superficial femoral artery and the profunda femoral artery, which don't compress because they're under arterial pressure. So they would compress if you really squash down hard on the patient, but that would be quite uncomfortable. This is what the setup of the scan looks like. If any of you have never been in to observe the ultrasound scans, it's very simple. My colleagues there always like to put themselves in their pants in pictures. We use color flow imaging, and we include looking at the profunda femoris vein in our scan protocol. This is a vein which gets omitted from scans on many protocols, and you can argue the toss one way or the other whether that's important. We very rarely find thrombus isolated to the profunda, but once in a while we do pick up a DVT that would be missed if that wasn't included in the protocol. And so all we do is we work our way down the femoral vein. So you can see here the vein being compressed at roughly 2 to 3 centimeter intervals as we work our way down the thigh of the patient. And that is again showing, I'll just run that again, showing the femoral vein compressing nice and cleanly all the way down the thigh. The color flow imaging is something that is useful from time to time. It shows where the veins are patent, but it doesn't exclude non-occlusive thrombus. So we don't rely on it wholly, but it's very useful as a problem solver in kind of trickier cases with difficult imaging. So what does an actual blood clot look like in a vein? Here you can see the common femoral vein underneath, they're not compressing, and you can make out some sort of what we call echogenic. That means it's generating echoes on the image underneath there, and you can see quite clearly that's a thrombosed common femoral vein. These are some still images, and again, looking along the length of the vein here, you can see that echogenic material inside the vein, and you can see where it relates to the long saphenous vein here that's still got a bit of flow, but through the junction into the deep vein, it's all thrombosed there. Another example here of some thrombus which extended all the way down right into the popliteal vein, and here we can see these are some of the muscular veins around the upper part of the calf. Not all thrombus looks the same, and in this case you can see there aren't any echoes generated from within the vein, but on compression you can see that vein is just not collapsing, and there are a few little echoes on the upper wall. But we have to be a little bit careful in a case like this not to press too hard, because we don't want to lead to any of that thrombus breaking off and going upwards where it shouldn't be. So that's it. Easy, or is it? Sometimes we have some challenging cases, and here's an example of a patient who had a swollen leg after a knee operation, and what you can see is right at the top we can make out the vein, but as we work our way down the thigh it's just completely lost in the depth of that image. And so that's very challenging for us because we can't confidently rule out a DVT at all based on these kinds of images. So we have to find some workarounds, and there are some that we can use. And here what we've done is change to a different ultrasound probe. So this is a probe that uses lower frequency sound waves, which allows the sound to penetrate deeper into the tissue. And we can now make out the vein collapsing all the way down the thigh. So we have some tips and tricks of the trade to be able to work around these challenging cases. We mustn't be fooled. This on a static image looks very much like echoes being generated from inside the vein, and you could easily be fooled into thinking that that's a thrombus in the common femoral vein. Here's the profunda femoris, femoral vein, and common femoral with the artery sitting on top. But actually, we have to remember that ultrasound is a dynamic imaging modality, and taking static images and reviewing them, it doesn't tell the full story. And what you can see on these images is as you squeeze the leg lower down to get the blood moving, you can see it's actually flowing through. And those echoes being generated are where the blood is moving slowly, and slow moving blood generates echoes. So that's another example of where we have to be a little bit careful with what we're seeing. Sometimes we get asked to say if thrombus is old or new, and it's a bit tricky, to be honest, and I don't think ultrasound is reliable, but this is a very good example of clearly old thrombus, or shouldn't really call it old thrombus, because once it's old, it's not really thrombus anymore. It's more fibrotic scarring inside the vein. And you can see both in the longitudinal picture and in the cross section, this very bright sort of white stuff on the inside of the vein is that fibrotic scarring. And we could say quite confidently that that's old scarring rather than acute DVT. So it's possible, but can be challenging to be relied on to age thrombus. Another example of the same thing, we can see that sort of bright echogenic material inside the vein, but you can see some of the vein has got some flow around it, whereas an acute thrombus would normally completely block the vein. So we've talked about scanning this section of the anatomy from the groin down to the knee so far, and we do that by compressing the vein all the way down. But what about the iliac veins? We can't really compress them because they're deep down inside the abdomen, and pressing on them doesn't give the same ability to collapse the veins, because they just move around with the soft, squishy stuff that's inside the abdomen. So we use an alternative for the iliac veins, and what we do is we look at the flow waveforms. This is Doppler ultrasound, spectral Doppler ultrasound shows us the pattern of flow in the vein. And what we can say is that the flow should be phasic with the patient's breathing. And if we see this phasicity with the patient's breathing, we're reasonably confident that that excludes any occlusion of the iliac vein segment. And here's an example of a case where the waveform is not phasic with the breathing. We can see a little bit of pulsation because it's right next to the artery, but there's no respiratory change here. And what we saw was this section of the vein here completely occluded. So we can use this sort of flow pattern to look at what's going on in the iliac vein higher up. What about the calf veins? This is the more controversial area. As we've mentioned, the NICE guidance doesn't include imaging of the calf veins. So let's talk about whether it's possible to do it, first of all. And I unequivocally say it is possible to do it, and this is how we go about doing it. And here are some images to prove it. So we can see a pair of perineal veins in the middle of the image, compressing nicely, running all the way down, and we can see posterior tibial veins a bit further up on the image, compressing under the probe pressure. So clearly it is possible. And we can formally diagnose a calf vein DVT. You can see a muscular vein here, the soleal vein, which isn't compressing. A little bit more difficult to spot than the examples in the thigh, but it's very clear to be seen. So why is it that the NICE guidance doesn't include imaging of the below-knee veins? I think there's a few key points. One, and probably most importantly, is that there's a very poor link between calf vein DVT and it progressing on to cause clinically significant pulmonary embolism. So therefore, there's a questionable need to treat calf vein DVT. And if we're not going to need to treat it, then why should we spend our time looking for it, is the argument. There's another point which says that ultrasound is less sensitive for the detection of calf vein DVT. And there's a perception that ultrasound for below knee veins is much more difficult to do, much harder to learn, requires much greater expertise. And I suppose that is true to a point. And because of that, there's a perceived lack of expertise in looking at below knee DVT. Personally, I think that's Disney logic. It's a bit strange and of an argument, and I'll try to explain why. It leads to a lot of missed opportunity to find a calf DVT, which may be the source of a patient's symptoms. We see frequently patients with localized pain in the calf, and it is because of calf DVT. And even if that patient doesn't necessarily need treatment for that calf DVT, at least we can then reassure the patient that we've found the cause of the symptoms, and that we can reassure them that it doesn't need to be treated, or perhaps it does need to be treated, but we can explain it with a clear answer for the patient. And it avoids confusion for primary care teams where you say, well, we haven't found a DVT, and you send the patient away, but they still haven't got an explanation for the pain in their calf. It also misses the opportunity to find the alternative diagnosis, muscle damage, Baker's cyst, or the other things that can go on in a patient's calf. And we can avoid having to bring the patient back for those repeat scans that I mentioned earlier. If we scan the whole leg on the first time, and we get good clear pictures, we can confidently rule out the DVT on day one and not have to keep bringing these patients back for repeat scans. But these are my opinions, and there are plenty of people out there who would challenge me on them. So I ask you to do the what if it was me test, and if you had a pain in your calf and you got referred for a DVT scan and the scan only went down to the knee, would you be happy to wait a week, come back and have the same repeat scan down to the knee, and no one ever actually examine your thigh, your calf, to sort of try and figure out what was wrong and what the pain was, whether it was DVT or a muscle tear or anything? Because we can find other pathologies. Here's some examples of a Ddimer and muscle injuries, and we can see Baker's cysts, and occasionally we can find clinically very significant problems. This is an example of a occlusion of the popliteal artery that was picked up on a DVT scan, and this is something which we get reasonably commonly from A&E patients sent up with unusual calf symptoms that are requested for a DVT ultrasound. And when you sort of talk to the patient a little bit more detailed, the symptoms are more arterial in nature, and this is potentially something that's a surgical emergency. So looking for alternative diagnoses is an important aspect. What about the fact that below-knee ultrasound is poorly sensitive? Well, that is true to a degree, and there are studies out there which show that the sensitivity of detecting DVT below the knee is lower. But all of those studies were done a long time ago when ultrasound looked like it does on the image on the left. This is the exact same image, but with all the modern additions that modern ultrasound scanners have. We have newer technologies which improve the image quality, and I don't think we could argue the fact that this is not a superior image to this. And so I think the sensitivity studies, if they were done again now, would have much higher sensitivity for below-knee DVT. But having said all that, there are some cases where it's just not possible to see the below-knee veins clearly all the way through. And I'm sure those of you who look at ultrasound reports will have seen this. If you're local departments are scanning below the knee, you'll have seen those reports which say poor images of the calf veins, can't exclude DVT in the calf, that sort of thing. And these are the images that we're talking about here, and you can see 2 centimeter thick edema, and with all the tricks of the trade, sometimes it's just not possible to see those veins in the calf perfectly well. So we're clear to report those limitations when we come across them. In the calf veins, we can sometimes get around these, and you can see, using our different probes again, we can see the calf veins quite well, and we can use the color flow imaging, and we can squeeze the calf and see that flow. But like I say, with the best will in the world, there are some patients who it's just not possible to confidently rule out small calf DVT. A little word on the superficial system. I focus purely on the deep system, but there are some guidelines out there about treating for superficial vein thrombus. So we always have a look at our patient's superficial veins as well. And here you can see some varicosities, and as you see there, you can see a big thrombus that's sitting in that varicose vein. Whether that's clinically important or not, I leave to the clinicians who read our reports to decide. But certainly some superficial vein thrombus can be quite extensive, and if it extends up, as this one did in this case, quite a long way in the leg, and sometimes goes through junctions with perforating veins and can actually propagate through into the deep system, that's certainly potentially important. So in conclusion, DVT scanning is quite quick, and it is quite easy to do if you have the right training and expertise. There's still some controversy, I think, about scanning the below knee veins, and my personal view is that a DVT scan for a patient with pain in the calf really should include imaging of the calf. And that's all I have for you. I hope that was what you were hoping for. And if there's any questions, I'll happily take them.
It was fascinating. Thanks so much, Ben. And those little videos are just hypnotic. I could watch them all day. And just a little note on the full leg scanning, the VT Getting It Right First Time report that's just been published asked that question about whether centres were just scanning proximally or whole leg, and 70% of those that responded, which I think was about 90 something centres, said that they did scan the whole leg. So I think that is the predominant practice in the UK. We have, sorry, were you going to add?
It's an interesting thing, and there are certainly places that are practicing both ways. And one of the things which I'm aware of is that I'm not sure that the nice guidance about the rescans is always followed properly in those centres which are only scanning down to the knee. And I've visited students in places who are repeat scanning everybody, irrespective of what the first scan showed and what the Ddimer and Wells score were, and some centres that are not bringing patients back for the repeat scan. So that's another thing. It sort of adds to a bit of confusion. If you just scan the whole leg on the first visit, then you can get it right first time, I guess.
Yeah, I agree. And of course, you've got some patients that you will lose to follow up. They won't come back for their second scan as well, which adds another dimension. We have a couple of comments and questions here. Isra has said that in a patient with a previous DVT and new symptoms of leg swelling on the same site as the previous DVT, when a scan report says chronic or old thrombus, but acute VT cannot be ruled out, what do you do? I'm guessing, Ben, that you'd say you'd hand that over to our team, to the DVT service.
Yeah, I think I wouldn't be the one to make a decision on that. Yeah. But I think, if there's old thrombus there, we know, don't we, that patients with previous thrombus have a higher risk of repeat acute DVT. So I wouldn't be averse to repeat scanning them. The ones which get me are when we've scanned a patient. Had one this week, in fact, an inpatient on one of our ITUs who had bilateral common femoral vein acute thrombus, and we had a request to scan them again about 6 days later, which said, please rule out DVT. I think that's a bit daft, but I think if there's a history of DVT there, it's sensible to look at them again if they have new symptoms.
Yeah, I agree. I think that's what we would do in that case that you've mentioned, Israel, is that we would invite them back for another scan in a week. And Sharon has said, regarding distal DVT, Ben, I've been involved in DVT service provision, which views whole limbs since 2005, and it's very refreshing listening to you.
Thanks. There is one risk to doing the whole leg service, which I should mention really, which is, as we've seen, ultrasound isn't perfect in below knee scanning, even in the best of hands. So there's the small possibility that if we think we've seen everything but actually missed a calf DVT, and we're not bringing those patients back for repeat scans in a week, there is that small possibility that something could propagate that we missed on the first scan, and without that safety net of the second scan, that could get completely missed. But thankfully, I think that's pretty rare.
Yeah, I can't think that we've seen that, and I think that's where the DVT service or whoever looks after and manages these patients come in, because it's our job then to safety net those patients and explain that we haven't found a DVT today. However, if your symptoms persist or worsen, then you must make sure that you represent. So yeah, thankfully, I don't think we've seen any of those. And that's all for the questions. Thank you so much, Ben. We've